We'll be lucky enough to have that start. You know, there's a psychological syndrome where you keep trying something that's broken. I forget what it's called. It's like, you know, your TV where it doesn't work, if you walk into the room and just try it just because it might work this time. I've been doing that with this laser pointer also. Okay. We're going to start with blood clotting. That's where we left off last time. Okay. The maintenance of blood volume in blood clotting is called hemostasis. Hemostasis is going on in your body constantly. It's a cessation of bleeding when a blood vessel is damaged, but you've got little microclots forming and breaking up constantly. But what happens is you've got on the inside of your vessels, veins, arteries, you have a layer of epithelial cells. Below the epithelial cells, you've got a layer of collagen. The epithelial cells protect or separate the blood and the platelets in that from the collagen. If the vein or vessel is damaged, you get exposure of the collagen. Exposing the collagen does three different things. It causes vasoconstriction. It causes formation of a platelet plug. Now, last week we showed you the platelets. On Thursday we showed you the platelets. Platelet plug. Platelets are the first thing that adhere to a cut, to the exposed collagen. They release factors that attract more platelets. There's also von Willebrand's factor that's released that causes the platelets to adhere even better. So if you get somebody who has a deficiency of von Willebrand's factor, they tend to bleed a lot more, a lot harder to get them to stop bleeding. And then finally, you get the formation of a fibrin plug. Fibrinogen is a protein in the plasma. It's soluble, and then through the action of thromboxane, it precipitates out and is released from the platelets at the platelet at the site of the injury. And so the platelets plug, and then at that point the fibrin weaves over it and just consolidates the plug. And at that point, after that, then it starts to contract and get smaller and just denser and still doing the plug thing. So we'll get on to that. Okay. Okay, blood clotting. Intact endothelium secretes prostacyclin. We talked to that. Prostacyclin is a type of... Lady of jelly.
Yay! I got candy today.
I brought candy today. But I only brought so much, so...
Because you have to open the packs and then throw it in the individual ones out.
Oh no, I got a box of them in there.
These are hard to open.
Prostaglandin. Remember, you have two types of prostaglandins that are secreted. Prostacyclin and PGI-1. Prostacyclin keeps platelets from adhering. PGI-1 helps platelets to adhere. So you have this antagonistic mechanism going on again. Because you certainly, if you don't have a cut and you don't have a need for platelets to be adhering, you don't want them sticking. You want them floating around to be ready and not causing microclots or emboli, which is what you would get. The emboli gets into the capillaries, gets into the lungs, then you've got a big problem. So, nitric oxide, which also vasodilates the vessels and inhibits platelet aggregation. So what happens is you've got the platelets there, but it is so critical that they don't clot until they're needed. Because let me clue you, if they clot when they don't, you're pretty much a goner. So, and then you have the CD39. It breaks down ADP into AMP and phosphorus. That again, you need the ADP for platelet aggregation. So if it's down into AMP, it's not going to work. So now you've got a cut. You've damaged the endothelium. You've exposed the collagen. Platelets immediately go and bind to the collagen. Von Willebrand factor comes in and makes them even stickier and helps hold them there. They recruit more platelets because a platelet, when it's floating in the plasma, is granulated. When it adheres, the granules come out. They attract more ADP. They attract more platelets. They make the platelets stickier. The idea is to plug whatever's bleeding as quickly as possible. Serotonin does vasoconstriction, and they release the thromboxane A. It's for sticky platelets, and it also starts breaking down, taking the soluble fibrinogen and turning it into insoluble fibrin. So, you've got your platelets, you've got your cut. Von Willebrand's factor, collagen, ADP to AMP, this is just kind of floating around. Here, the collagen is exposed. Here, the collagen is not exposed. You've got a cut, the collagen is exposed, the platelets are coming in, they're attaching to the collagen, ADP is released, it's bringing more platelets in, you're forming this big mound of platelets in the cut, that's the first place that they're going to go, and that's the first line of defense. Then, as the thromboxane is released, you see these green fibers representing fibrin. So fibrinogen is broken down, or is made insoluble, and it binds, and it just weaves this together, forms a fibrin plug. Fibrinogen is converted into fibrin. Intrinsic factor. You have two pathways in the body for clotting. You have the intrinsic pathway, which would be like this, with platelet exposed collagen. Factor VIII activates a cascade of other blood factors. Now your factors go from 13 down, what's that?
Isn't that 7?
Or I'm sorry, factor 7, yeah. You go from 13 down to 2 or 3. And they have this is one thing I wish they would change. I wish they'd start at 12 or 13 and say 13 does 12, activates 11, activates 10, activates 9, activates 8. It doesn't work that way. They numbered them as they discovered them. So 13 activates 3, which activates 5, which activates 9. And that's not the correct order. Don't write that down. We'll get to it. But anyway, it is what you would call what type of feedback? Give me the...
Let's go. Can be positive. I like this.
It's positive feedback because the activation of one activates several more. The reaction grows. Eventually, you're going to get to a negative feedback because it's got to stop at some point. But your clotting pathways, extrinsic and intrinsic, start out as a positive feedback. This is the intrinsic exposure to collagen. Here, you've got your red cells, you've got your platelets, you've got the fibrin weaved in. This is a platelet plug with fibrin. So, factor 1 is fibrinogen, it's converted to fibrin. Factor 2, prothrombin, converted to thrombin. This starts breaking down the fibrin at some point. And we'll get into that, because at some point your plug has to break down as it's, as the vein heals and everything gets back to normal, because you don't want these interruptions or these roughness to interfere with the blood flow. Tissue thromboplastin, that's part of the extrinsic. When you cut yourself, you're getting thromboplastin from the tissue in there, which starts a pathway which is much faster than the intrinsic pathway. The tissue thrombin, when we draw blood, if you've ever had your blood drawn, you notice that they draw it in a very specific order. You draw the red tops first because you're going to let it clot, so you don't really care how much tissue thromboplastin is in there. When you go through the tissue to get into the vein, you're going to release thromboplastin. You don't want it in your clotting studies and that. So you draw your red tops and you suck it into the red top where it doesn't make any difference. Then you're going to draw your sodium citrate tubes, your blue top, and you're going to use those for clotting studies. And then you're going to draw either your heparin or your EDTA. Because if they're anticoagulated and you don't want the heparin in the clotting study tubes, but it doesn't matter what else it gets into. So you draw them in a very specific order. Calcium is a cofactor, factor 4. Your anticoagulants, your sodium citrate, your EDTA, ethylene diamine tetraacetic acid, and that'll be a spelling test, spelling question on your next test. It'll be the only one I'll have to grade manually. For versity. Yeah. Those bind calcium. They bind to calcium, the blood doesn't clot. So we use that to make plasma. We also use heparin. Heparin binds the thrombin, and it keeps the blood from clotting. However, that will eventually reverse and the blood will clot, usually long after we're done with it. But EDTA or citrate, when it binds calcium, that blood's not clotting anymore. Another cofactor is proaccelerin, proconvertin, and they go through there. Factor 8 is anti-hemophilic factor. You have two types. You have von Willebrand's, which affects how the platelets bind, and you have factor 8A, which is what you find in the hemophiliacs. A lack of this, it's generally through inbreeding. It's X chromosomal, so you see it in the males, and it's generally throughout the royal families of Europe because, again, did I say something?
No.
Did you get it?
I think it's the phylos over,
Yeah. It's because of the inbreeding, they've just bred this back into themselves instead of breeding with us commoners and getting it out of the system for a while. That's a big thing that happened in the Russian Revolution. That Rasputin was supposedly able to cure the hemophiliac that plagued the Tsarist family, and that's how he got into power, and was the start of the fall. So you've got your 13 factors. I'm not going to ask you to memorize them, though I would like you to know that you got the fibrinogen, the calcium, the factor 8, and the thromboplastin are ones I might ask you about, but I'm not going to ask you about Hagman or stabilizing factors. Okay, blood clotting. Fibrin. Calcium and phospholipids from the platelets convert prothrombin to the active enzyme thrombin, which converts fibrinogen to fibrin. The platelets are not strong enough to stop the bleeding, God knows, especially in an arterial type cut. So it has to get other factors in there to help plug the gap. And fibrin is it. Fibrinogen is converted to fibrin via one of the two pathways. You have the extrinsic by the tissue factor. Again, this is the fastest. And it's more direct. Now, vitamin K is needed to form some of these factors. Vitamin K, both for the intrinsic and the extrinsic pathway. You have a drug they call Coumadin, or warfarin. What's that?
Rat poison, right?
That's how it started, was rat poison. It was developed in the 30s or early 40s as rat poison. And that's decon. That's where decon got its name. Coumadin. And then they found that it could interfere with this clotting, so they give it with people with atrial fibrillation or other deep vein thrombosis to keep clots from happening. It affects the amount of vitamin K dependent factors, and it's really the only oral anticoagulant that works well. So here you have your extrinsic pathway, your intrinsic, and then the common. Extrinsic is tissue activator. You get the cut in the tissue, the extrinsic is activated. Factor 7 is activated. The complex factor, calcium phospholipids, goes into the common pathway, activates 10, which activates 5, which converts prothrombin to thrombin, fibrinogen to fibrin. Factor 13 is fibrin stabilizing, and then you get your fibrin polymer. The intrinsic pathway, activators, collagen. The way blood clots in a test tube is because of the interaction between the glass and the blood. In fact, it begins the intrinsic pathway. 12 to 12 activated, 9 to 9 activated, 11 to 11 activated, activates 8, goes up, goes back into the common pathway. And you still end up with the fibrinogen. Now, your PTT will pick up the intrinsic pathway, activated partial thromboplastin. Your ProTime picks up the extrinsic pathway. So if I have somebody that's coming into the lab and I think they've got hemophilia, doing a ProTime may or may not tell you anything, but doing a PTT would give you an idea of if that intrinsic pathway is messed up or has some sort of problem. Okay, blood clotting, acquired and inherited clotting disorders. Vitamin K, inadequate formation of prothrombin and other clotting factors in the liver. It can be in hepatitis, or it can be on purpose by giving Coumadin. Inherited, hemophilia, defective factor 8A, recessive trait, X chromosome, delayed formation of fibrin, really delayed formation of fibrin. These guys bleed badly. Before the days of concentrated factor 8, we would pump plasma, and we would pump hundreds of units of plasma into these people to get them enough factor 8 to start clotting. Von Willebrand's, again, von Willebrand's is factor deficiency so that your platelets don't stick well. Hemophiliac B is Christmas disease, delayed formation of fibrin again. That's factor 11. I'm sorry, factor 9. Anticoagulants. Aspirin inhibits the prostaglandin. The what? COX-1, COX-2, COX-3. Cooxygenase enzyme.
It's cost for
No, it's COX-1.
aspirin?
Yeah. So COX-1. So what happens is your platelets are not a living cell. They're a cell fragment. So if you've got aspirin in and it's inhibited the platelet, that platelet's inhibited for the life of the platelet. The 7 to 10 days that that platelet's in circulation, it just plain doesn't work anymore. So if I get somebody in with a GI bleed and they've been taking aspirin, the platelets aren't working, there's nothing that I can give them that are going to make those platelets work again. So I have to go out to Red Cross and I have to get, big bags of platelets, platelet pheresis, and give it to them so that they'll clot. Coumarin, Coumadin, warfarin, rat poison inhibits vitamin K. Heparin inhibits the activity of thrombin. Now in heparin, they will give it in the hospital, usually IV, because it acts very quickly. If you give Coumadin, you've got to let it deplete the vitamin K stores of the body. Heparin works like that. Calcium, you don't give calcium to people for clotting. That's used in the tubes and in the laboratory. Citrate combines with calcium. Citrate or EDTA. Actually, in the old days, back about the time I started, we used citrate in the blood bags to keep the blood from clotting for transfusion purposes. And when I was working down in Mexico, we were lucky to have whatever we had. So they pulled out, I had to give a transfusion to a lady down there, and they pulled out these old bags of citrate, and the bags have been expired 10 years. Still worked. We got her a transfusion. But that causes other problems. Now the other anticoagulant is EDTA, ethylene diamine tetraacetic acid. And that again binds calcium. Now that one you actually will give to a human on occasion in vivo, because if you have a very high calcium and you need to get rid of it, it chelates it, and so you titrate the dose so that they don't start bleeding, but you get rid of the calcium out of the blood system. You would see a high calcium in somebody, say, that has a bone cancer and the bone is breaking down, and the calcium is being released into the blood. Anticoagulants prevented with clotting can be prevented with certain drugs. Calcium chelators, sodium citrate or EDTA. Heparin blocks thrombin. Coumarin, again, vitamin K. Okay, structure of the heart. You got a 4-chamber heart. Right atrium receives deoxygenated blood from the body via what? Two major veins. You already got it. Inferior and superior vena cava. Left atrium receives oxygenated blood from the lungs. Right ventricle pumps the deoxygenated blood to the lungs. Left ventricle pumps the oxygenated blood to the body. So the atriums are receiving the blood either from the veins or from the lungs. They're responsible for making sure the ventricles are filled. The ventricles are the ones that push the blood out either back to the lungs if it's venous blood, or back to the out to the body if it's oxygenated blood. Structure of the heart. You've got a fibrous skeleton that separates the chambers, separates the atria from the ventricles. The atria work as one unit. The ventricles work as another unit. The atria are what accept the blood, again, from the body or the lungs. The atria fill. The pressure of blood in the atria starts blood flowing into the ventricles. Your bicuspid and tricuspid valves open just from the pressure of the blood in the atrial, not the contraction, just the pressure, the weight of the blood filling it. And they will start filling the ventricles. The ventricles will fill to about 80% without the atria doing anything. The atria then will contract and push that other 20% or so of the blood into the ventricles. Ventricles are full. A couple of milliseconds later, the ventricles contract, push the blood out to the body or out to the lungs. Okay? So you've got atria. Go into a big mansion, the atrium of a building, the atrium of a church, the entranceway. It's the blood from the body or from the lungs. Better not lose this, it's not mine. Fibrous skeleton separates the atria from the ventricles. The work is one unit, ventricles is another. Forms the annuli fibrosa, which holds the heart, which hold in heart valves. You have 4 valves in the heart. You have the semilunar valves, you have the tricuspid, and you have the bicuspid. The semilunar valves are in the ventricles. Now the valves are essentially a flap. If you have pressure up here pushing down, when the pressure gets enough, the flap opens and the blood rushes out. When it's done contracting, there's more pressure in the artery, pushing back this way, pushes it back up and closes it. Now, your bicuspid valves are on the ventricles going out into pulmonary artery and the aorta. You have your tricuspid and bicuspid. The tricuspid because there's 3 flaps, the bicuspid because there's 2 flaps. Go from the atria into the ventricle. And as I remember, the tricuspid is in the right atria into the right ventricle. Bicuspid is in the left. Pulmonary goes between the heart and the lungs. Blood pumps to the lungs via the pulmonary artery. Blood returns to the heart via the pulmonary veins. The pulmonary veins are the only veins in the body that carry what? Oxygenated blood. That's just a trivia question. Might be a test question, but it's more of a trivia question. What did you learn in physiology today?
Something about that.
Yeah. Blood returns to the heart via the pulmonary veins. So this is a portal system. Pulmonary is a portal type system. Systemic is between the heart and the body tissues. It pumps out via the aorta, comes out of the top of the heart, and it's a U-turn, goes down all through the body. Blood returns to the heart via the superior inferior vena cava, the veins. So, your heart, your blue is obviously veins, bringing blood back in. Not obviously. Your pulmonary artery, again, is venous. Your pulmonary vein, as soon as I find it here, are right here, bringing oxygenated blood back to the heart. Your blood is coming out of the heart, averaging about 120 millimeters of pressure. Your blood in the veins averages about 2 millimeters of pressure. And we'll get into that, into the blood pressure. But the blood, the take-home message is that what comes out of the heart through the right ventricle goes to the lungs, gets oxygenated. How does oxygenation take place in the lungs? It comes into the alveoli. What happens to the, in the alveoli, to the oxygen or the CO2? Diffusion. What, you want another word?
No.
Okay, well, she got it right. Diffusion. I still got a few more of those.
Oh, they're the good
Yeah, they're jelly bellies. I was sent on an errand before I came to class.
I did.
My wife.
We like her. That's why it's Easter.
I didn't tell her it was my jelly bellies for class. Anyway. Deoxygenated blood's going to the lungs. You get oxygenated diffusion. Simple diffusion. You're down to 1 cell thickness in the alveoli. CO2 diffuses out, oxygen diffuses back in. Goes back to the lung, back to the heart, goes into the left atrium, into the left ventricle, and it shoots out through the aorta. The aorta, it goes down through the body, into the brain, everywhere. It's the arteries, arterioles, capillaries, comes out of the capillaries into venules, into the veins, and into the big veins, and then back into the heart. And it just goes around and round. The heart pumps 5 to 6 liters a minute. The body, has 5 to 6, I was just waiting for that to get out of the way. The body has 5 to 6 liters of blood. Figure the heart's going to pump the blood through the entire body once a minute. So when hormones get released, it doesn't take very long to get to where they're going.
How often? Once a month.
Once a minute.
Oh.
5 liters a minute, somewhere around there. Arterioventricular valves located between the atria and ventricles. I got it right. Tricuspid is in the right atrium ventricle, bicuspid is in the left. Semilunar valves located between the ventricles and the arteries leaving the heart. Pulmonary between the right ventricle and the pulmonary trunk. Aorta is the left ventricle and aorta. So you have your semilunar valves, you have your tricuspid. You see that it has 3 flaps, your bicuspid has 2. And here's, again, another diagram of the heart. So you have here, another thing I want to point out, semilunar valves, left atrium, mitral, bicuspid valve, chordate, tendineae. These help hold the valves in place, as do the papillary muscles. When something happens to these, they get stretched, the muscles get weak, you start getting regurgitation of the blood. This is what you hear in a heart murmur. The blood is not, when the flap comes up, it may not come up into the right position, so when the ventricles contract, it pushes blood back into the atrium. Again, you get what they call a heart murmur. Now, I've had plenty of people when I was in class that had heart murmurs, and I'm sorry, but I'll be damned if I could check them out. Some people could hear them, I couldn't hear them. But, it's kind of like calculus. I always wonder if I went back and did it again, if I could ever get it to work right. I doubt it.
Where do they put the pacemakers?
They put the pacemakers in the right atrium, up in this area, in the sinoatrial area. And we'll get to that. Because that's where your electrical depolarization of the heart starts. Yeah. Heart sounds. You have the love dove. Closing of the AV valves, closing of the semilunar valves. Just a fraction of a second apart. And again, this is very, it's very necessary. One, the depolarization of the heart is quick through the atrium, but the atrium and the ventricles are not well connected for the electrical stimulation of the heart. There is a delay of about 2 milliseconds because the idea is you want the atrium to contract, filling the ventricles, and then have the ventricles contract, ejecting as much blood into the system as possible. And that's generally 60 to 70%. It's called the ejection fraction. And when we get critical patients in the hospital, we bring in an ultrasound. They all get an ejection fraction just to so they know how to deal with any or that part of heart problems. Anyway, what you hear, the lub is the atrioventricular valves closing. The dub is the ventricular or the semilunar valves closing. Okay, heart murmurs. Abnormal sounds are produced by the blood flow through the heart. It may be caused by defects in the valves. Mitral stenosis, the mitral valve calcifies. That's the valve out of the left ventricle into the aorta is the mitral valve. Between the left atrium and the left ventricle. May result in pulmonary hypertension because it's pushing blood back into the pulmonary artery. Incompetent valves do not close properly, damage to the papillary muscles. Those are the muscles around the valve that hold them in place. Septal defects. When you're in utero, you have a septal, not a defect, it's that way. Because the baby's getting the oxygen from the mother, and you essentially have a septal defect because you're not pushing blood to the lungs until you're born. Then when you're born and the oxygen is coming into the lungs, this septal defect closes and the baby starts breathing. But a septal defect is simply a hole in the heart, a hole between the atrium and the ventricles, or between the atrium and the atriums. And if it's bad enough and doesn't close up with drugs, they end up having to go in and doing open heart surgery and closing it. Once it's closed, it's closed. The baby, the child, generally doesn't have any more problems. Heart murmur, again, you're getting blood regurgitating back where it's not supposed to. Cardiac cycle. Oh, we may get into chapter 15 today. Okay. Repeating pattern of contraction and relaxation. Systole, contraction of the heart muscles. Diastole, relaxation of the heart muscles. So when you do a blood pressure, systole and blood pressure is 120/80. Systole is the 120. 80 is the relaxation. You get that 80 millimeters of mercury just from the pressure, from the elasticity of the veins, pushing back on the heart. Cardiac cycle. Systole is about 0.3 seconds. The ventricles contract. Atria are relaxed. The ventricles are pushing the blood out into the peripheral circulation or to the lungs. Diastole, everything in the ventricles are relaxing and filling. Part of diastole is the atria contract, and the atria are relaxed during systole. So the atria are contracted when the ventricles, are relaxed and the ventricles contract. toward the end of the ventricle contraction, the atria relax and start filling with blood again. Ventricles begin contraction, pressure rises, AV valves, atrioventricular valves close. So the ventricles are full. They start to contract. You don't want blood being pushed back into the atrium because you just drained it into the ventricles, so it's there to push out into the aorta and the pulmonary artery. So the back pressure closes the bicuspid and tricuspid valves. As pressure builds, the semilunar valves open, allowing the blood to be ejected into the arteries, pulmonary and aortic. And then as the ventricular contraction ends, the pressure in the arteries pushes back against the semilunar valves and closes the valves. Pressure in the ventricles falls below that of the atria, the AV valves open, and the ventricle fills. So now you've got this vacuum, for lack of a better word. You've got this contracted ventricle. It relaxes. The pressure is lower than the blood in the atrium. The atrium has been filling from the vena cava. And the bicuspid and tricuspid valves open, and blood again starts flowing into the ventricles. And the cycle begins again. And right before the ventricles contract, the atria contract, sending the last 20% or so of blood into the ventricles, so the ventricles have all the blood they can hold before they send it out to the body. Now, another thing you need to realize is that you really can't have a mismatch here. Because if you start getting more blood into the atrium than is going out into the ventricles, it's going to back up into the pulmonary artery, and you're going to get various hypertensions. This is what you see with some of the heart diseases where you have to increase the contractions to keep from getting the hypertension. You get the edema because it's pushed out, the fluid's pushed out into the tissue. We'll get to that when we talk about the lymphatic system. That's why they're giving people digitalis and other drugs that aid in the contraction. Cardiac cycle and pressure. You have your sounds, your volume. As your pressure goes up, the volume of blood in the heart goes down because your ventricles pumping it out. The pressure is going up because you have this big muscle contracting, creating enough pressure to push the blood out through the semilunar valves into where it's going. One right here, isovolumetric contraction. It's contracting, but what does isovolumetric mean? Iso, not moving. Right. You got to share with her. She should.
She didn't want to do it. It's cool.
You don't want anything better.
I'll say, oh no, okay. I'll
She has kids.
She has kids. Ejection. The atria are relaxed. Your ejection, your ventricles are pushing blood out into the system. Isovolumetric relaxation, again, your ventricles, your semilunar valves go. You have filling. You have rapid filling. You have atrial contraction that finishes the filling, and boom. Your ventricles are getting ready. Your AV valves close. Your ventricles contract, and the whole thing begins again. Electrical activity in the electrocardiogram. Cardiac muscles are interconnected. They have gap junctions. They stain dark blue on the stain, intercalated discs. We talked about this. Once the stimulus is applied, there's nothing stopping it. It goes from one muscle cell to the other. The area of the heart that contracts from one stimulation is called the myocardium. That is a connection of all the cardiac cells. The cardiac muscle cells are the myocardium. The atria and ventricles are separated electrically, again, by the fibrous skeleton. That not only physically separates the atria and the ventricles, it electrically separates them. And so how does the electrical stimulation get into the ventricles? Okay, in the heart, you have the SA node, you have the sinoatrial node. That's where your depolarization, your electrical stimulation starts. It goes through the atria, hits this fibrous skeleton, gets to another node they call the AV, atrioventricular node. It has to pass through this node, and then it very rapidly spreads through the ventricles, through the bundle of His and the Purkinje fibers in the right and left branch. So, have you heard of somebody coming in, the doctor says, you've got a bundle branch block? What's happened is the electricity comes out of the SA, goes through the atrium, hits the AV node, gets in through the bundle of His, hits either the right or left bundles, which go to different parts of the ventricles, and something blocks it. Cut, disease, I don't know. That's when you need to put a different type of pacemaker in to get that ventricle to fire. So you've got a bundle branch block, you're not going to get the ejection you need to operate efficiently. Anyway, we'll get to that. They're separated by the fibrous skeleton. SA node, sinoatrial node is a pacemaker. It's in the right atrium. Potential is slow, spontaneous. It moves at, 0.8 meters a second, maybe a little slower than that. It's, so you've got a slow depolarization of the atrium. At a minus 40 millivolts, voltage-gated calcium channels open, triggering an action potential contraction. Repolarization is the opening of potassium-gated channels. Now, what's different? We talked about this in chapter 12. What's different? These calcium channels open. In a normal axon, the calcium channels open, they cause the presynaptic gates to open, the release of acetylcholine goes through over the synaptic cleft. I'm surprised I remembered all that, huh? And hits the postsynaptic receptors, opens, allows sodium-gated channels to open, which carries the action potential across the synapse and down the next nerve. What happens in the heart? Because this isn't what happens in the heart. What? Nope. Not even close. I brought something to get you guys involved. Come on. Calcium stimulating calcium. Remember? The calcium gates open. There's a few calcium gates. When that hits a minus 40 that open, they open up and then they stimulate a lot of calcium gates. That's what causes the action potential. We'll just leave that up here. Just repolarization again, opening a voltage of potassium gates. Potassium volt goes out, hyperpolarizes, and everything starts going back together. Okay, electrical activity. voltage gated calcium channels. Now you have your HCN channels. This is in the SA node. I don't know what HCN stands for. They're just the HCN channels. These open up. Allow the calcium channels to open and allow the action potential. Pacemaker cells in the sinoatrial node depolarize spontaneously. Your heart, if your SA, if your pacemaker, if your stops working, your heart will still beat 20 to 30 beats a second. If you have a bundle branch block, your Purkinje fibers in the ventricles will still continue to beat. Again, 15, 20, maybe 30 beats a minute. Not enough for you to do anything but lay down and be on oxygen. Pacemaker, depolarize spontaneously, but at a rate they do not, at which they can so be modulated. Epinephrine, norepinephrine come from where? I don't have to remember that. He's already tested us on that. Epinephrine, norepinephrine. What gland secretes them? Which one? There's two adrenal glands.
The medulla.
Adrenal medulla. Give the lady a jelly bit. Yeah, pretty good. You get them right to you. Adrenal medulla. That's part of your sympathetic system, your fight or flight. Epinephrine, norepinephrine is secreted from the adrenal medulla. It helps speed up the cardiac rate. Parasympathetic neurons secrete acetylcholine, opens potassium channels. Potassium channels do what? Depolarize? Hyperpolarize. Hyperpolarize. So that it slows down the heart rate. The parasympathetic system hyperpolarizes, slows down the heart rate. The sympathetic system excites the heart rate. Parasympathetic system those impulses are transferred via what nerve?
Say that again?
Parasympathetic system. There's one nerve that travels through much of the body. The wandering nerve. The wandering nerve. The vagus nerve. The 10th cranial nerve. It's one of the few that I asked you to memorize. But, well, he's tested it on us. We can forget it. Slows the heart rate. Vagus nerve slows the heart rate. Sympathetic system speeds up the heart rate with epinephrine and norepinephrine. Electrical activity, myocardial action potentials. Resting potential is about a -90. Depolarized to threshold by action at the SA node. Like we said, the sinoatrial node is where it starts. The depolarization spreads through the atrium, hits the AV node, it's delayed by a few milliseconds. Then it goes into the ventricle through the bundle of His, into the Purkinje fibers, into your right and left branches. That's really quick. Nice, quick depolarization, a nice, hard, heavy contraction from the ventricles. Voltage-gated sodium channels open to membrane potential plateaus at 15 millivolts for 2 to 300 milliseconds. Due to the balance between slow influx of calcium and the efflux, or the outgoing of the potassium. there is a long pause as far as for repolarization in the heart. 2 to 300 milliseconds, the heart is resting. It's the plateau phase. You see it on the EKG. I mean, you got to give the thing some rest. It's going to be 80 times a minute for, 80, 90, 100 years. You ought to let it rest at some point. But more potassium channels are opened, repolarization occurs. Repolarization in the heart, comparatively, is very slow. You get a little bit of sodium in to start it. You have the calcium, goes in slow. Then you have the more rapid calcium in. Then you have potassium out as part of the repolarization. But you're also looking at 400 milliseconds. You're looking at 400 milliseconds. You look at the nerves, the firing of the nerves and some of the sympathetic and other parasympathetic systems, you're talking 8 to 10 milliseconds. Much slower in the heart. Action potentials are spread via the intercalated discs, gap junctions, AV node at the base of the right atrium, and bundles of His conducted into the ventricles, just like we were talking about. Intraventricular septum, the bundles of His divide into the bundle branches. Bundle branches become the Purkinje fibers, which stimulate ventricular contraction. Much faster, much more powerful than the atrial contraction. All the atrium is doing is filling the ventricles. The ventricles contraction is pushing blood through the entire body. Ventricle muscles are a lot thicker. The left is much thicker than the right, because the right is just doing it through the pulmonary system. The left is doing it through the entire body. Now you get somebody with pulmonary hypertension, and you look at an echo of them, you'll see a significant thickening of the muscle in the right ventricle, simply because it's working against so much more pressure. So your SA node, intraatrial septum, atrial ventricular bundle here, bundle of His, right and left bundle branches. Here's your Purkinje fibers. Here's your AV node. Your AV node is carrying the electrical stimulation into the ventricles. Here's your bundles of His right here. Then it comes down, it goes into the branches. Notice how thick your left ventricle is, the muscle. Thinner in the right ventricle, much thinner in your atrium. All these guys are doing is pushing blood through the tricuspid and the bicuspid valves into the ventricles. This is actually a pretty good diagram. Conduction of impulses. Action potentials from the SA node spread rapidly, 0.8 to 1 meters per second. Very slow through the AV node, like we said. This accounts for the time delay, allowing the ventricles to fill before the ventricles contract. Picks up in ventricles, bundles of His, 5 meters a second. Very quick. 0.1 to 0.2 seconds after the atria contract, the ventricles contract. Very, very efficient. Maybe we don't get to. These are just your receptors, your membrane receptors. Refractory periods. Because atria and ventricle contract as a single unit, they cannot sustain a contraction. They contract, they relax, they're repolarized, then they contract again. The action potential of cardiac cell is long. They have a long refractory period before they can contract again. Long, you're talking about a few tenths of a second, but it allows the muscle to relax. So here's a refractive period here. Contraction, refractory, atrial contraction, ventricle. Electrocardiogram, EKG, ECG. Anybody, who's done one of these? So what happens with an electrocardiogram is the body, with all the electrolytes and the water and the fluid in it, is a very good conductor of electricity. You've got this electrical current running over the surface of the heart. These electrical currents get projected to the skin surface. And we can pick them up on meters and diagrams, and we can look at them. Now, by placing different electrodes on different parts, the back, the legs, the arms, the chest, and by varying how the meter looks at them, as opposed to one being the ground and the other being the positive, you can paint essentially an electrical three-dimensional picture of the heart. Normally they're using now a 12 to 18 lead. In the old days, you would have, you'd put 3 leads on, and you'd take one, and then you'd move the leads, and then you'd take another, and you'd move the leads, and then you'd take another, to again try to paint this picture. Now they put 7 or 8 leads, and then the computer does the rest. And it varies between. But the instrument records electrical activity of the heart picked up by the movement of ions in the tissue on the skin. So here's a normal electrocardiogram. You have your P wave. This is your PR interval from here to here. You have your QRS. You have your plateau. You have your T wave. And then you start over again. When you measure the rhythm, you measure from the R to R. So when we do this in the lab, you actually, on your Flexicomp, on your computers, it measures it for you. But there are calculations. When you do this, when you look at an EKG strip, it's divided into millimeter and centimeter divisions. And there's a very quick calculation just counting the number of divisions, the number of big divisions, that you can calculate the heart rate. So, P wave. This is when your atria are contracting. QRS to the T is when your ventricles are contracting. P wave is atrial depolarization. QRS is ventricle depolarization. ST segment is a plateau phase. This is your ST segment. Nothing's really happening there. Your T wave is a ventricular repolarization. Now, I said that wrong before. I said contraction, it's depolarization. Contraction takes place a fraction of a second after that. So, here's your PR, QRS, your ST interval. There's your QRS complex there. Right here, atria is filling, atrial are filled, these valves are opening, your atrial are contracting. Pushing the blood down in from here, down into the ventricles. Here, your ventricles are filled. Here, the ventricles are filled and starting to contract. Here they're contracting, and now they're starting to repolarize, which is your T wave. Here they are depolarizing and contracting. Here your ventricles are repolarizing, and that's in here in your QRS, but you don't see it because there's so much more electrical activity in the ventricle. I said your atrium are repolarizing. You don't see that on EKG because it's covered up by the ventricular contraction. Okay, this is talking about where they put the leads, bipolar limb leads, lead 1 on the right arm and right leg, lead 2, right arm and left leg, lead 3, left arm and left leg. We're not going to, other than doing that in the lab, we're not going to worry about that. But by putting the leads here, and you put more leads on this when you use a 12 lead, you literally are painting an electrical picture of your heart. Unipolar leads record the voltage between a single electrode in the body and the one built into the machine. The limb leads on your arms and legs go to the right arm, left arm, 6 chest leads. Now you're looking at, this is a 6-lead electrocardiogram. And again, they're in your book, I'm not going to worry about where the leads go. I'm certainly not going to quite test you. Love occurs after the QRS rate. Remember, the love is what closing? What? The love is from a valve closing. Which valve? Atrioventricular valves. Okay, bicuspid or tricuspid valve. The dub is the beginning of the T wave, and that is what valves closing? Semilunar. Right. Oh, you didn't answer that? Oh, sorry, but you already got one. Okay, again, here is the pressure with the hard sounds. We will go through this more when we're doing the lab. Blood vessels. Arteries, arterioles. The arteries are the big ones. The arterioles are smaller. Capillaries, venules, and veins. Big, smaller, small, down to one cell. 7 to 10 microns in diameter, one epithelial cell thick. The capillaries are there for exchange of gases and nutrients. Blood sugar goes out, waste products come in. Carbon dioxide comes in, oxygen goes out. All done by diffusion. Then the veins, the capillaries go into venules, small veins, which go into larger veins, which come back to the heart. Now your normal blood pressure, 120/80 in the arteries. So at one end of the capillary, the arterial end of the capillary, the pressure is pretty high. That forces fluid back into the tissue, out of the capillary, along with the nutrients. Doesn't force the blood cells. Blood cells are too thick. The venules start picking up some fluid, but the pressure is much lower. Instead of 120 millimeters of mercury, it's about 2 millimeters of mercury. And then the veins, again, it's not much more than that. How does the blood get all the way back up to the heart? Okay, what kind of pumps? How does it get back up to the heart? Now, obviously, you can't, once you push it through the capillaries, you don't have enough pressure to push it up that high.
Wait, by the vein?
Well, it goes up through the veins, yes. Two things. You know, I'd give her another candy. She's already got one. She's crying. In the veins that you don't have in the arteries are valves. So the valves, as the blood moves up, it will not move back down. You have valves, when you guys get to the point that you're putting IVs in, you'll thread this IV into a vein and you'll hit a valve, and you might as well start over again because you're not going anywhere. Pull it out and try another. Also, you have what they call skeletal pumps. The veins are soft. They're not big and thick like the arteries. So as your muscles move, they literally push on the veins, collapse the veins, and push blood up toward the heart, up into the vena cavas and into the heart. And the valves keep the blood from coming back down. So if you're a traffic cop and you're standing in the middle of an intersection for hours and you're not really walking around, your legs swell up. You're standing at a parade, your legs may swell up just because the blood's pooling down there because you're not using the muscles to push it back up to the heart. It doesn't happen if you're hiking, but if you're standing there, it certainly will. Okay, so artery, arterial circuit. You have a large artery, you have endothelium, tunica interna, tunica media, tunica externa. Medium size arteries, arterioles, don't have as many layers. And then you have the capillaries. Capillaries go into the capillary bed. You have three types of capillaries. You have the fenestrated and two others. Continuous, fenestrated, and discontinuous. Thank you very much. The continuous capillaries, very tightly bound to the basement membrane. No gaps in between the cells. Where would you find the continuous capillaries? Where don't you want fluid going through the capillary?
Brain, lungs, muscles. Just kidding, lungs. Like the first answer.
Is that your final answer?
Sure.
Blood-brain barrier. Blood-brain barrier. Notice that is when we talked about the blood-brain barrier, there's a penocytosis in those capillaries that carry drugs and oxygen, glucose, and that across through the cell and then release it on the inside or the other side. That's why there's drugs that we can give that will not get across, and why we have to have certain drugs that can get across the blood-brain barrier. Your fenestrated have larger pores, and your discontinuous are like the bone marrow, and they're huge, that things can get through the capillary and into the tissue. Now, your veins, your venules, tunica externa, endothelium, and they're showing a little bit of a valve in there. A little bit bigger, you have tunica externa, tunica media, tunica interna, and then here again is a valve. The valves, like a flap valve. The blood goes through it, it tries to come back down, the valves close, the blood cannot move in the opposite direction. Large vein, again, you have the tunica externa, media, interna, endothelium, the lining inside, and the lumen. Now, again, what does the endothelium do? They all have endothelium. It doesn't show it there. They all have endothelium. What does it do? What does it protect?
Blood vessels.
if I have platelets, what keeps them from aggregating in the veins? What separates them from the collagen? Endothelium. It's the inside lining of the veins. I think we hit that a little bit earlier today. It's not a trick question. The endothelium line's the inside. Again, when we talk back about the clotting mechanism, it separates the inside of the veins from the collagen, because if the platelet gets in touch with the collagen, it starts the activation, the stickiness, and you have a clot forming. You get a cut or a breakage in there, then you've got the collagen exposed, again, you strike the clot or your coagulation or homeostatic process. Blood vessels. I think we've gone through that. You do have medarterials, you have sphincters. We talked about that when we talked about the smooth muscle. Remember, the muscle is not only going lengthwise down the vein, but it also wraps around. And this is generally part of the sympathetic system, because what happens in the fight or flight syndrome?
Things close off.
Things close off. The veins are closed off. You don't need blood to your skin. You need it to your brain, to your heart, to your liver. To get glucose out to the muscles, you need it to the muscles. Anybody seen anybody so scared they turn white? Literally, they turn white. The blood is cut off to the skin. It's their fight or flight. It's all going to the internal heart, brain, lungs, liver, muscles, getting ready to run. Yeah.
Why is it that humans can't control that ability, but yet there's marine mammals such as whales that can?
I don't know that if I'm a 50-ton blue whale that anything's going to scare me all that bad.
No, I mean the
But
controlling.
I think I don't know. I think it's probably more for thermal regulation than anything else. Because they go from Arctic water down to tropical water in their migrations. I think it's much more part of thermal regulation. But I don't know that for sure. Okay. But you have these shunts. You have the sphincters. You can shut off this flow. And you can shunt blood to where it needs to go as part of the fight or flight syndrome. Arteries and veins. The walls of the arteries and veins have three tunings. Intimate, inner, simple squamous endothelium on a basement membrane, connective tissue. Media, middle layer composed of smooth muscle. Externa, outer layer composed of connective tissue. They're both essentially the same. The arteries are thicker than the veins because of the pressure that they're up against. This becomes important when we start looking at arterial sclerosis and where fat and monocytes and that are getting laid down. Let's see, how much do we have left, or do we want to? You know, let's go ahead and take a break here, because I don't want you to go up there and have the cafeteria closed on you. So let's just stop here for a couple of minutes. Let's take about 20 minutes.